Atrial flutter. Classification, clinical manifestations. Atrial flutter, AFL, is a rapid regular atrial tachyarrhythmia, that is less common than paroxysmal supraventricular tachycardias or atrial fibrillation. It is infrequent in normal individuals. With underlying atrial abnormalities, such as mitral valve disease, congenital heart disease, cardiomyopathy, pulmonary disease, and coronary artery disease, it may occur at any age. Subgroups at particularly high risk for developing AFL are patients who have undergone surgery for complex congenital heart disease, most notably, transposition of the great arteries, tetralogy of Fallot, and atrial septal defects. The electrophysiological classification of atrial tachycardia and atrial flutter is discussed earlier. Types of atrial flutter. 1. Isthmus-dependent AFL, in which the cavo-tricuspid isthmus is an essential part of the reentrant circuit. 2. Non-isthmus-dependent AFL, any other type. This is a schematic showing the cavo-tricuspid isthmus, that is the area between the inferior vena cava and the tricuspid valve ring, closely related to the eustachian valve of the inferior vena cava, and the thebetian valve of the coronary sinus. Types of isthmus-dependent AFL. 1. Classic AFL, counterclockwise or clockwise. 2. Double wave reentry. 3. Lower loop reentry. 4. Intra-isthmus reentry. Classic AFL. In classic AFL, the reentrant circuit is very large, with its boundaries including crista terminalis, inferior vena cava opening and its eustachian valve, coronary sinus opening and its thebetian valve, cavo-tricuspid isthmus, tricuspid annulus, atrial septum, sometimes involving the fossa ovalis itself. The crista terminalis is a vertical ridge of smooth myocardium within the right atrium, on its lateral wall, separating its posterior smooth part from the anterior rough part, extending between the right side of the orifice of superior vena cava down to the right side of the eustachian valve of the inferior vena cava. On the external aspect of RA, it corresponds to a groove, called the sulcus terminalis. Reminding you of the embryological origin of the atria. Right atrium. Anterior rough part is formed by the right half on the primitive atrium. Posterior smooth part is formed by the right horn of the sinus venosus. Right atrioventricular canal is also incorporated into it. Left atrium. Anterior rough part is formed by the left half on the primitive atrium. Posterior smooth part is formed by the proximal parts of the pulmonary veins. Left atrioventricular canal is also incorporated into it. Double wave reentry. Double wave reentry is created when a critically timed atrial extrastimulus is introduced into a classic flutter circuit. Two wave fronts will occupy the circuit simultaneously, causing acceleration of the tachycardia rate, but with identical surface and intracardiac ECG morphology. This rhythm rarely lasts for more than a few beats, and can serve as a trigger for atrial fibrillation. Lower loop reentry. In this type of AFL, the reentrant circuit is situated around the inferior vena cava, traveling either in a counterclockwise or a clockwise rotation. It is usually transient, and often coexists with classic AFL. Intra-isthmus reentry. The reentrant circuit in this type lies between the cavo-tricuspid isthmus and the coronary sinus opening. Non-isthmus dependent atrial flutter may originate in the right or left atria. In the right atrium. 1. Upper loop reentry, in high right atrium, involving the crista terminalis and superior vena cava orifice. It may rotate in a counterclockwise or clockwise direction. 2. Lesional, scar, atrial flutter, reentry occurs around a scar, such as atriotomy, intra-atrial baffle of mustard or Senning operation, Mays operation, atrial septal defect closure, or radiofrequency ablation. In the left atrium. It may be found in patients with or without surgery. Sites of reentry include the mitral annulus, pulmonary veins, atrial septum, and Mays procedure scar. Clinical patterns of atrial flutter. 1. Paroxysmal, lasts for seconds to hours, may occur in patients with no structural heart disease, or in patients with acute disease processes, for example, exacerbation of pulmonary disease, following cardiac or pulmonary surgery, or during acute myocardial infarction. 2. Persistent, lasts for days or weeks. 3. Chronic, does not revert if untreated, often fails to revert with attempted treatment, and if reverted will frequently recur despite therapy. This is less common, and occurs with chronic diseases, for example, valvular heart disease, ischemic heart disease, and cardiomyopathy. Symptoms of atrial flutter may include palpitations, lightheadedness, fatigue, dyspnea, acute pulmonary edema, or acute coronary syndrome. The severity of symptoms usually depends on the ventricular rate during atrial flutter, presence of structural heart disease, and the baseline left ventricular function. Atrial rate in AFL. In isthmus-dependent atrial flutter, 200 to 400 per minute. In non-isthmus-dependent AFL, 140 to 240 per minute, similar to paroxysmal SVT. With a healthy AV node, 1-to-1 conduction can result in hypotension, syncope, or circulatory collapse. Even with controlled ventricular response, sustained atrial flutter can cause debilitating symptoms, due to loss of AV synchrony, and can contribute to thromboembolic complications. Thank you.